Well, depending on where you're calling in from in the world, good morning, good afternoon, perhaps good evening to everybody here today. And thank you so much for coming to our event today. This is the breast cancer expert panel for Black in Cancer. So yes, I've already seen somebody say where they're tuning in from. So if you can just pop in the chat where you're tuning in from, that would be wonderful. Ralph, can I ask you to share the slides and then I'll introduce our wonderful panel?
Absolutely.
Great. And for those of you who don't know, my name is Dr. Julia Morris. I am one of the co-directors of mentorship and outreach for Black in Cancer. And thank you very much for joining us today. So I'm just going to introduce our wonderful panel. So first of all, we have Dr. Karen Winkfield. Dr. Karen is a radiation oncologist specializing in the treatment of blood and breast cancer. She is an implementation scientist focused on improving health outcomes for underserved populations through community-engaged research and community-based initiatives designed to improve access to healthcare, including clinical trials. Her leadership roles have focused on developing bidirectional communication between researchers and community to ensure equitable access to care regardless of race, ethnicity, geographic location, or socioeconomic states. She also espouses workforce diversity as a means to improve health equity. Dr. Winkfield served as chair of ASCO or ASCO's Health Equity Committee from 2016 to 2017, and now serves as the chair of ASCO's Workforce Diversity Task Force. She was recently named Executive Director of the Meharry Vanderbilt Alliance. Dr. Karen, welcome. And next up, we have Dr. Barbara Iyen. So Dr. Barbara is a general practitioner in an inner city practice in Derby, UK. She's also an honorary clinical assistant professor with the School of Medicine at the University of Nottingham, UK. After obtaining her basic medical training from the University of Benin, Nigeria, she obtained a master's degree in international public health with distinction and a PhD in epidemiology and public health from the University of Nottingham, UK. For her PhD research, she developed an early warning prognostic score for early identification or diagnosis of lung cancer in primary care. This work was subsequently cited in the UK National Institutes for Health and Care Excellence, or NICE, in 2015, clinical guidelines on recognition and referral of suspected cancer. Following her PhD, she undertook and completed clinical training in general practice and has continued to combine her clinical work with academic research and teaching. Through working in an ethnically diverse inner city general practice, Dr. Iyen is exposed to the wide variations of health and well-being outcomes resulting from inequalities. She has a significant expertise in clinical epidemiology. Her research interests are in cardiovascular and cardiometabolic disease epidemiology, lipid disorders, and ethnic variations in disease risk outcomes. Dr. Barbara, welcome.
Thank you for having me.
Oh, thank you. Next up, we have Dr. Shirley Mauzoul. Dr. Shirley graduated with her Bachelor's of Science in Nursing from City College of New York in 1996. She later attended a New York university and received her Master's of Arts in Advanced Practice Nursing, Adult Primary Care in 2003. Dr. Mauzoul pursued her terminal degree and obtained her Doctor of Nursing Practice in Leadership at Chamberlain College of Nursing in 2019. She served as an adjunct clinical instructor for undergraduate nursing students at New York University and Columbia University from 2001 to 2002. Dr. Mauzoul has been a staff member of New York University Langone Health since in 1997 and works in the pre-admission testing division, and she also works at Memorial Sloan Kettering Cancer Center as an advanced practice provider since 2005. Her clinical expertise includes neurology, neurosurgery, orthopedics, and acute chronic pain management. She presently works in the post-anesthesia care unit at MSKCC Josie Robertson Surgery Center. Dr. Shirley, welcome.
Thank you.
And finally, we have Wilhelmina Grant. I'm not going to read this, it's a little bit small, sorry, but I've got a separate write-up here. So Wilhelmina Grant is a self-taught, Harlem-based visual arts artist, arts instructor, and author. Wilhelmina is also a cancer survivor and the founder of Sister Incorporated, which stands for Survivors Inspiring Sisters Throughout Art and Advocacy for Health. Amazing. And this is an arts-based non-profit organization which seeks to inform, encourage, and facilitate access to early detection of breast cancer, connecting the medically underserved to free screening services. Wilhelmina, thank you for coming and welcome. Yeah, great. So welcome to all of our panelists. So we're going to get started with some questions. We've just got less than an hour to get through our questions. So I'm going to open up the floor to our panelists. And my first question is, what is breast cancer when it comes to your perspective? And anybody can answer this first question.
So Ms. Julia, thank you so much. And I want to thank Black in Cancer, and I want to thank everyone who's putting on this wonderful event. This is Black Family Cancer Awareness Week from the FDA. This is an initiative that they have, and so it's really wonderful that we're all coming together from around the world. That's why we've got Germany, the Netherlands, we've got US in the house, so welcome everyone, and thank you so much for doing this. Let me just say, a lot of folks are confused about cancer. They're afraid of it, understandably so. Before we had a lot of the new treatments, cancer used to be a death sentence. It is no longer the case. And I think that's one of the biggest myths. If people don't take anything else from today's event, know that breast cancer is not a death sentence, and it's treatable. And what I tell people is that breast cancer is a spectrum of diseases. It is not one type of cancer. It is not just one disease. And so this is important because sometimes people will say, well, my friend had breast cancer and this is what happened to them, and somebody else had something else happen. Your treatment is going to be just for you. And so cancer is just when one of the cells in your body, we have billions of cells that make up our body. Some cells are eye cells, some cells are cells that make up your hair, that make up your skin, make up your breast tissue. Any one of those cells has a program inside that tells it when to grow and when to stop growing. A cancer happens when that cell bypasses that regular mechanism. When it says, you know what, I know that I see that stop sign, but I'm going to go through it anyway. And your cells are able to then start to grow in an unchecked manner. That's what a cancer is. And sometimes the cancers can be localized, and sometimes they start to spread or metastasize. But regardless, whatever tissue that cancer started from, that's the type of cancer it is. So in the breast, there are two different types of tissues that are really specific to breast. It's the duct tissue, that's the tubes in the breast that bring milk out to the nipple complex, and then the lobules, which is where the milk is made for a woman who's actually nursing. Men can get breast cancer, by the way, as well. This is not just for women. But those two tissues are specific to the breast. And so if those cells start to grow in an atypical or abnormal manner, then that becomes a breast cancer. Remember, there's other tissues like fat and blood cells themselves. Those things can also become cancer, but they're not typically called breast cancer. They are called a cancer that is involving the breast. So I just want to make that little bit of a distinction. Here's the deal. Breast cancer, again, is a spectrum of diseases. There can be breast cancers that have special proteins on the outside. They could have estrogen receptors or progesterone receptors or other types of proteins that help us figure out how to target those cancers. And so that's why I want to make it clear. Breast cancer is a spectrum of diseases. There are lots of different things that a care team will look at. things underneath the microscope, things that might be specific to the tumor itself, also your genetic makeup. These are things that help stratify how we're actually going to treat patients who have breast cancer. I'm going to let some of my other colleagues chime in.
Wonderful. Thank you, Dr. Karen.
I want to jump in right quick and just say, just very briefly, what breast cancer is to me is something that is highly survivable if detected early. This year, I'm celebrating 27 years and counting of survivorship.
Fantastic.
I'll be quiet for now.
No, that's wonderful. Thank you for sharing. That's amazing. Amazing. Dr. Barbara?
To be fair, I think Karen has given a very great overview of breast cancer, and I think she kind of embodies what breast cancer is to me as well. I mean, the way I describe breast cancer to my patients is just as she said, our body is made up of cells which grow and divide throughout our lifetime. And in breast cancer, these cells become, the growth and division of the cells become abnormal and uncontrollable. And obviously, it causes the block of cells called the tumor. But at the same time, these cells have the ability to spread and invade other tissue and can potentially be life-threatening. So again, as she says, it's not a life sentence, but potentially can be life-threatening.
Great. Thank you so much, Dr. Barbara. Just as a follow-up question to that initial general question about breast cancer, what are the features or signs that women should look out for when it comes to breast cancer? What abnormalities can we look out for? And again, I'll throw that question out to the whole panel.
Usually, one can find that there's change in the shape or size or appearance of the breast. There may be discharge from the nipple. There may be what appears to be like a breast rash, change of the skin overall. For some, there may be an inverted or pulling of the nipple that was never apparent before. So these are like important signs of breast cancer that one should go and see their clinician for evaluation.
Thank you very much, Dr. Shirley. So we're looking at structural changes in the breast or abnormalities which you know your body. When things are looking a bit different, that's when you should go to your general practitioner in the first instance to find out what's going on.
So Julia, let me just say that the majority of women don't have any signs, right? And so that's the importance of screening. So we've already heard Ms. Wilhelmina talk about the importance of early detection, right? So if found early enough, and this is why we have screening in the form of mammograms. So screening mammography has really shifted and changed when we can treat breast cancer. Oftentimes we're finding things so small that they cannot be felt. But I do agree with Ms. Shirley and Dr. Shirley. The important thing is knowing your body. And I can tell you there are lots of women who are a little bit weird about knowing their own body, but it's important to know your body, know what your breasts feel like, know if there's any changes or anything in terms of appearance, but also feel. The shower is a great place to do that, right? As you run your hand alongside your body. If you find any knots or lumps or changes, those are things to observe over time. And if they don't change, a lot of women have fibrocystic breasts, which means they can get nodules that form in the breast that come and go. Again, if things stay, that's when it's important to kind of get things checked out. But I do want to point out that a lot of women who have breast cancer are actually diagnosed at the time of mammogram. So this is why screening is very, very important.
That's a really, really good point. Thank you so much, Dr. Karen. And thank you, Dr. Shirley, as well, for answering that first question as well. This is really, really informative. So just moving on to our next question. So who gets breast cancer? So how does family history play a role in being at risk for breast cancer? And does it depend on the type of cancer as well? So if you have a parent who had bowel cancer, are you at risk for breast cancer or etc.? And can I direct that to Dr. Barbara?
Yeah, okay. Sure. So interestingly, sometimes I wish there was a prototype for the ideal breast cancer patient. But unfortunately, there are several, so there's no particular cause. There's no simple cause for breast cancer, but there are certain factors that we call risk factors that make people more likely to have breast cancer. Now, some of these factors we can actually control, and some of them we can do nothing about. So when we're talking about the risk factors that we have no control over, the first one of them is being a woman. So by virtue of being a woman, you already have a higher risk than a man of having breast cancer. So we know that 99% of breast cancer cases are in women, and slightly less than 1% you have in men. Now, age, the older you get, the more likely your chances of getting breast cancer. So 80% of breast cancer cases are in women over 50. Obviously, we have the genetic risk factors. So people who carry the BRCA1, BRCA2 gene, as we probably all know, have a very high risk of breast cancer, as well as other types of cancer, like ovarian cancer. Then family history, which you just spoke about just now, having a significant family history also increases the risk of breast cancer. Now, particularly family history of breast and ovarian cancer in a close family relative is very important. So if you've had a mom, dad, brother, sister, or children with breast cancer or ovarian, well, obviously not the males with ovarian cancer, but a close family relative with these type of cancers strongly increase your risk of having breast cancer. Now, race and ethnic background as well. Now, we know that being white gives you, white women have a slightly higher risk of having breast cancer or higher incidence of breast cancer, but Black women are more likely to die from it. So the mortality is higher in Black women. Now, some women have denser breast tissue. So if you have more gland and less fatty tissue, you also have a higher risk of having breast cancer. And also you also have, so looking at your menstrual cycle. So women who have very early periods, very early onset of their first periods, and women who have very late menopause have slightly higher risks of breast cancer. Now, that brings me on to the next part, which is for the other things that we can actually just control, the modifiable risk factors. Now, for those ones, we have things like alcohol consumption, smoking, reproduction, so not having children early in life or having your first child later in life slightly increases the risk of having breast cancer. Not breastfeeding as well slightly increases the risk. Certain types of birth control pills. We also know about things like the hormone replacement therapy, which women use after menopause. These things increase the risk. And being overweight, so being obese or overweight, and also exposure to radiation. So those things, obviously, we can control to an extent. But in all of this, basically, some women have a combination of these risk factors and don't have breast cancer. So again, it's one of those things where we don't quite know these risk factors kind of work in unison, but as we know, genetic risk factors, as you brought out just now, do play a strong risk. So if you have a patient or a woman who has a strong family history, we strongly advise them to be on the alert for other risk factors that they can actually modify, and at the same time, make sure they're in contact with a healthcare professional so they can get screened early and checked out very, very often to make sure they don't develop breast cancer.
Wonderful. Thank you so much, Dr. Barbara. And we know that you're based in the UK. So I was just wondering if any of our panelists based in the USA have anything else to add on to that or different perspective.
Yeah, so I was going to say, and thank you so much for that, Dr. Barbara, that anyone with breasts can get breast cancer. Okay, so let's just make that clear. And again, this is why it's important to make sure you know your body. There were some messages in the chat where, again, there are some differences in terms of the age of screening. So screening mammograms in the United States start at age 40. So, and then annual versus UK, which I believe it starts at 50 and it's every other year. But one of the things that in the United States we've started to do is actually start doing a baseline mammogram starting at age 35. So from age 35 to 40, women in the United States can actually get screened earlier. And the reason why is because we are starting to see younger and younger women develop breast cancer. And that is really particularly so in the Black community, right? So Dr. Barbara talked about different genetic abnormalities. The BRCA1 and 2 genes, or BRCA1 and 2 genes, are known to be more evident in the Black community. But oftentimes, our families might not even be aware. So it's important to know that most women who develop breast cancer do not have a family history. It's called sporadic. So there's not a family history. So if you say, well, my mother didn't have breast cancer, or my grandmother didn't have breast cancer, so I'm not at risk, that's not the case. If you have breast, you are at risk. So this is why it's important to think about ways like Dr. Barber talked about risk reduction. So first, I think one of the things that is really important from a United States standpoint is that unfortunately our diet is filled with lots of processed food as well. So I think it's important to think about diet nutrition as well. I know we might talk a little bit about prevention strategies later on, but I do think it's important to know anyone with breast has a risk for getting breast cancer. So you must know your body, please. When you are eligible for screening, start having those conversations with your doctor so you can be screened. And if indeed you do have a family history of either breast or ovarian, as Dr. Barbara mentioned, or even prostate cancer, if you have a family history of prostate cancer, or even pancreatic cancer, these are some syndromes that may be tied in. If you have a family history of cancer, talk to your doctor about whether or not you may need to get screened earlier, or whether there are different strategies to kind of think about that may help raise your awareness around breast cancer for either you or your spouse. So again, we've got men on this line as well. We're talking about, obviously women being most at risk, but, for every 100 women with breast cancer, there's one man with breast cancer. So we know that men can get breast cancer as well. So please, everyone, just be aware of your body.
I want to jump in right here. Thank you, Dr. Karen, for mentioning early detection and getting your baseline mammograms at age 35. I was diagnosed at age 37, and I presented at the doctor's office with a painful lump, and I was dismissed without the benefit of a mammogram because I was under 40. I am an African-American woman. I was told that African-Americans are not diagnosed as often. I had a painful lump, which was not one of the criteria for breast cancer, and I did not have a family history. And what ended up happening is that I had to advocate for myself and go to another place and say, well, I have this painful lump. I don't know what this is. Tell me what this is. I want to get out of pain, and if I don't have breast cancer, prove it to me. So for me, being an advocate for myself and knowing my body and knowing something was different, and wanting to get out of pain was a motivator for me. So knowing one's body is very, very important, and to push to find out what is going on.
Thank you so much for that, Wilhelmina. I think that is a key takeaway for today, is that if we feel something is wrong with our bodies, we need to advocate for ourselves. So thank you so much for sharing that part of your story. Does anybody else have anything to add? Dr. Shirley, perhaps?
No, I think it's actually a good sign that, we're able to know what our bodies feel like. I think and Dr. Karen and Dr. Wilhelmina, you can chime in on this. Sometimes cancerous lumps could be fixed to the skin. Not in all cases, but if there's an abnormal growth, sometimes the cancer scale would adhere to the skin of the breast or the chest wall. And that's usually probably associated with advanced cancer.
Yeah, absolutely. And so those are things, obviously, we want to try to avoid those late stage, because the earlier we find the cancers, the better, as Ms. Wilhelmina said. But yes, there can be some skin changes, et cetera. Let me just address, there was a message that came through the chat that asked about why we're seeing cancers in younger women. Very good question. I always remind folks that Black bodies don't matter to a lot of folks. And we need to change that. We need to make sure that people start to see us and start to document what's happening in a faithful way, including how we are interacting with the healthcare system. There's been a lot of research that's this descriptive stuff, looking at large databases. And, my thing is garbage in, garbage out. So if you're not even capturing the data adequately in terms of who people are, where they're coming from, what their backgrounds are, it's really hard to say kind of what's happening. And so we have seen over the past several decades more impact and more emphasis placed on capturing where people are coming from. So yeah, some of the increase in terms of when we're seeing, oh wow, now, I used to be able to say white women got breast cancer at a higher rate than black women, but in the United States, that number has evened up, right? So black women are now getting it at the same rate, but I think part of it is because we're capturing the data appropriately, and more black women are getting screened in the United States, which is great. But I must say, Dr. Barbara mentioned a few risk factors that are extraordinarily important, at least for the United States population. Obesity. Obesity is a modifiable risk factor for cancer, not just breast cancer, but many cancers. And so in the United States, when we look at the obesity epidemic in the Black community, about 70%, 70% of Black people in the United States are overweight or obese, which means that the risk of developing cancers is much higher. And remember, when you have adipose excess fat tissue or adipose tissue, that can get converted to estrogens, which then can drive some of the cancers that we're seeing, breast cancers and some of the gynecologic cancers. So I think, obviously there's a combination of things. Yes, there's more awareness. I do think that is a huge factor of being aware now. And there are also, again, remember, triple negative breast cancer that we see, the ones that do not have estrogen or progesterone or the HER2 new proteins on the outside of those cancers, that triple negative breast cancer, we are seeing more in Black women and in young Black women, and it oftentimes is associated with that BRCA1 mutation. So I do think that even awareness around genetic abnormalities, genetic predisposition, that's important. And this is why I'm a huge advocate of women, particularly Black women and Black men, for enrolling and being participants in research, in cancer research, because again, Black bodies didn't matter, so we were oftentimes excluded from that. And so we really need to understand more about what are some of the things happening behind the scenes biologically, what are the exposures, whether it be stress exposures, exposures to some of the chemicals or other things. We need to understand that better, and the best way to do that is for us to really advocate to be included in many of the research, the cancer research in particular, that's happening.
Wonderful. Thank you very much, Dr. Karen. Sorry, Dr. Barbara, were you going to jump in there? Or?
No. I was just going to say that's really interesting, because I think one of the main drivers when it comes to not understanding why Black women obviously the incidence rate in Black women has been found to be almost as the same as in white women. But in terms of having more aggressive cancers at diagnosis, having been younger at the time of diagnosis, and all of those things, the truth is there's not much research when it comes to Black women or I'll say Black people in general. And one of the things that brings me to is like the screening in the UK. So I know in the US, screening is at age 40, and I think in New York, for example, the Governor Cuomo has recently signed a bill into law to start earlier breast cancer screening for Black women at age 35. Now in the UK, screening is at age 50. And to be fair, we can't quite justify screening at an earlier age, because based on the available data, highest risk, women are known to be at highest risk of breast cancer at the age of 50 and over. So until we can actually prove that it will be, there's more pros than cons in having breast cancer screening at an earlier age, unfortunately, things will have to stay the same. So yeah, so it kind of draws back to the same issue of having Black people involved in research so we can actually drive change with the evidence.
Wonderful. Thank you very much, Dr. Barbara. It's kind of like a crazy cycle in terms of we're not going to screen younger unless we detect younger, but then you can't detect younger unless doesn't make sense. But that's how it is in the UK at the moment. Just two things I wanted to pick up on before we carry on with our questions. So we've heard about these genes, BRCA1, BRCA2. Just to clarify, BRCA1 or BRCA1 or 2 stands for breast cancer susceptibility gene 1 and 2. And essentially, if you carry mutations in these genes, that means you're at higher risk of breast and ovarian cancer. And obviously, men and women can get breast cancer and ovarian cancers just in women. The other thing I wanted to highlight is tomorrow we have an event called Creating a Healthy Diet, and it really focuses on nutrition, and this has come up time and time again in our discussion so far. So if you're not signed up for that event tomorrow, please do sign up for it. Let's learn about how we can look after our bodies. So wonderful. So there is another question in the chat. I think I've just lost track of it. I'll find it in a second. But I just have a question for Wilhelmina. So you've already spoken to us about you were diagnosed with breast cancer at age 37. You spoke about advocating for yourself. So what was your approach for that? So I guess you went to one doctor, and then how did you navigate trying to get diagnosed and then treated?
Well, when I was turned away from the first center and told that I could not get a mammogram because I didn't have a referral from a doctor and I was under 40 and I had a painful lump, etc., I called my gynecologist's office and asked for him to write a referral for me so I could go to a center and then get a mammogram. It wasn't made very easy. And he said he agreed with the center that I went to that, well, you're much too young. You don't have breast cancer. You probably just have a cyst. Put a warm or cold compress on it. So I fired him immediately. And I called his associate and gave her the story and asked for a written referral to a doctor so that I could get a mammogram. She did provide it, and I went and she provided the name of a place I could go and get a mammogram at a different mammography center. And I did get a mammogram. And besides that, the doctor there gave me a needle biopsy the same day because she did feel something see something suspicious. And by the way, Dr. Shirley, it was on my chest wall. I was one of those patients that had a breast cancer attached to the chest wall. And a week later, I got the diagnosis that it was stage 2A. And after surgery, I found out I had 5 lymph nodes. So it was pretty advanced for the size that it was. It was a tiny, tiny tumor about the size of a pea, but it had already advanced to my lymph nodes.
Wow.
So it really took some work to get the diagnosis and have some satisfaction that what was going on in my body was indeed something serious. But I was told to walk away, just put a warm or cold compress on it. And I'm not sure how much race played into it or what, because I did have very good insurance at that time. So I'm not sure what was the problem with dismissing me. So, but I was pretty much a fighter. I said, no, I need to know what's going on. And I think more people need to stand up for themselves or bring someone with you and ask a lot of questions and do your research. And I didn't think I had breast cancer. I just thought I had a painful lump in my breast, on my chest, whatever, and I wanted to get out of pain. So whatever the condition may be, I think we need to remember that we have the right to stand up for ourselves and find out definitively what's going on.
Now, insurance coverage explains for like 50% of survival disparity, which is alarming. You know, I don't know what would make that situation better for everyone, including women of color, African American women, when they go and seek care.
Mm-hmm.
Well, if I understand your comment correctly, Dr. Shirley, this is the reason why I started my organization, to make people aware that there are services free of charge provided by the state where they can get mammograms. And if they do not have insurance and they are diagnosed, then they're automatically taken into the Medicaid system and are given treatment, surgery, and etc.
Yeah. So one of the things, Ms. Wilhelmina, thank you so much for sharing again your perspective, I think the patient perspective is always most important, right? And hearing from you the lessons learned. This was many years ago, right? So your diagnosis was over 2 decades ago, but not much has changed, unfortunately. And I don't think that it's really related to race. I think that when young women walk through the door, or even adolescents, it could be young men who may have a thing. They oftentimes are not taken seriously because, you know, oh, well, you're young, right? That's always the thing. You're too young for this or too young for that. And so that's why in the United States, at least, adolescent and young adult, that category is one of the most underserved patients with respect to cancer care, right? And adolescents, kind of age 15 to 19, they do get cancers. But then up to age 40, you think about all the young Black women in particular who are being diagnosed with breast cancer, or men who have testicular cancer, right? They fall into that age range, and so they are very underserved. And it's something that we've got to raise awareness, not just to oncologists, because we as oncologists know that it's really, at least in the United States, the gatekeepers sometimes are primary care providers and primary care teams, and really educating them about the importance of not dismissing kind of people who are coming with issues. And so I think that's hard, at least the way in the United States it runs. Primary care teams are often very overwhelmed. So you bring up, again, the importance of advocacy and self-advocacy. And for those who may not be able to do that for themselves, having someone who could come along with them to do that is really, really critical. But we also know that that's not always the case. It's not always the opportunity to do that. You know, Dr. Shirley mentioned insurance as being a barrier. At least in the United States, it certainly can be a barrier to screening and also to having access to care. But oftentimes it is that lack of awareness, the lack of knowledge. So that's why this this is so important that we're having this discussion today, because people don't oftentimes know, they don't have the knowledge, they don't necessarily know when to get screened or to be aware of things and changes in their body or how to advocate for themselves. Again, one of the challenges I find for my patients, at least, particularly patients of color or for those who have lower socioeconomic status, they often have to choose between work and going to the doctor. Because they're only paid for the hours that they work. And so that's a challenge in the United States when people have these their wage earned jobs where, you know, man, the doctor's office is only open from 9 a.m. to 5 p.m., right? And so then when do I kind of make this appointment? Because if I make the appointment, I may have to miss work. And that takes time off. So there are some strategies, at least in the United States, around trying to open up centers for longer periods of time. People are starting to use urgent care more than the emergency room, which, you know, that's not the best place to get care. I always recommend that individuals have a primary care team that they work with. That inclusive of physicians and advanced practitioners that can really help them when they do have a problem. But it does require establishing care. And in the United States, in order to establish care, you have to have the insurance. So it goes back to what Dr. Shirley's talking about. So to your point, Julia, you were talking about how convoluted some of this can be. It all is interwoven. And this is why it's really important for us to start looking at the social determinants of health, which include kind of people's background, their education, their access to insurance, and all of those things along the spectrum, because they certainly impact our ability to take the best care of ourselves that we can.
Thank you very much, Dr. Karen, for that summary. Really, really clear. That's wonderful. So far we've spoken about knowing your body, screening, we've spoken about nutrition. So let's just narrow in now on mammograms, so the screening. So in the US, we know that it starts age 40, in the UK, age 50. So what actually does a mammogram entail? And I'll throw that out to any member of the panel, so we can hear from a specialist or a patient perspective.
Okay, so can I go here?
Yeah, sure.
A mammogram is essentially an X-ray of the breast. It's done to identify the presence of a tumor or a lump in the breast. And it can actually identify cancers when they're too small to be seen or felt. Okay, so that's why it's used as a screening tool, because generally you don't need to have any symptoms. It's usually a painless procedure. It takes about 20 to 30 minutes. And in the UK, after a mammogram, a woman gets sent a result. So results get sent out to the woman and her GP within 2 weeks of having the procedure. So again, as I alluded to earlier, we use the mammogram as a screening tool for all women registered with a general practitioner in the UK, between the ages of 50 and 71. So pretty much up until their 71st birthday. And however, there's a slight caveat there. So while we know that there is an age range during which women are called in for mammogram every 3 years, so I need to add that part. So it's every 3 years they have mammograms. However, as a general practitioner, we are actually giving guidelines to refer women for screening if they are thought to be at high risk of breast cancer. So a woman that has any concerns about breast cancer doesn't have to wait to get to the age of 50 before she has her first screen. So any concerns, speak to your healthcare practitioner and you will get referred if we've done a risk assessment and we think you are high risk.
So again, the difference between the UK and the US and the United States, it's annual screening mammograms. And so we've also moved in terms of technology away from just using plain films to digital mammography, which just means that it's a little bit more sensitive. And then a layer on top of that now is three-dimensional mammograms. So I actually always recommend, particularly for African-American women, breast cancer in Black women, our breast tissue tends to be denser. So sometimes there can be individuals say, I just had my mammogram and they didn't see anything and I felt a lump 3 months later. Well, some of it is related to potentially technique and how the mammogram was actually given, or even whether or not it's three-dimensional or not. So if you have dense breast, it can be harder to look at the plain film. And do know, I think there can be a little bit of discomfort. I try to tell people that it's not going to be painless, because I tell you, those of us who've had them, they can be a little uncomfortable when your breast gets compressed, but it's really a way to flatten out the tissue to make it so that any little areas and that can be visualized. And so there might be a little discomfort, but it literally lasts for seconds once that compression happens, and then there's a release. So for some people who are afraid of that, I always say, well, look, you can take an ibuprofen or something like that if you don't have any contraindications to taking that. It's something that you can certainly take beforehand, or if you're feeling uncomfortable afterward. But the mammogram itself is very easy. In the United States, same thing. The results tend to get sent to both the primary provider and as well as the patient. But in the United States, you do not need a primary care provider to make the referral. So you can actually go and get screening on your own if you don't have a primary care provider.
Yeah. All right. So I'm just picking up on what you said about breast density. So yes, I agree with you 100%. Younger women, so apart from African-American women, so younger women in general have denser breasts, right? So, and dense breast tissue makes mammograms less clear to interpret, and the lumps are harder to see. So what generally happens is, if I have a young patient who's less than 35, for example, who's referred to secondary care, they usually don't have mammograms, so they have an ultrasound scan. So generally, mammograms are only done in women over 35 who are thought to be at risk of cancer, but then over 50 is done as a screening tool.
Wonderful. Thank you, Dr. Karen and Dr. Barbara. I think some of the key takeaways I'm taking away from that is that mammograms, or screening in general, Dr. Barbara, you've just mentioned ultrasounds. It can detect asymptomatic breast cancer. And that's something that I didn't know. If there is no lump, you didn't know, you go for screening and then they find something. So that is something really key for women, younger and older, to be aware that, when you're invited to go for screening, do go, because it can save your life.
Also take into consideration if there's a genetic history of breast cancer, screening can begin as early as 25, and for women with history of breast cancer.
Mm-hmm. Yes, indeed. Thank you very much, Dr. Shirley. Wonderful. And I guess we've kind of already covered this, because in addition to going to your screening, the other prevention methods are nutrition, and looking after your body and knowing your body as well. Are there any other any other ways we can prevent breast cancer, other than looking after ourselves, exercising, etc.?
So one of the things that go ahead, Dr. Shirley.
What was mentioned earlier with regards to obesity, there's also the comorbidities that come along with obesity, which is hypertension, chronic kidney disease. Those comorbidities can actually complicate the cancer diagnosis. So, just to put that in perspective, if we can generally, take care of ourselves, incorporate, good nutrition, exercise, we can, somehow decrease our comorbidities that can complicate a pre-existing issue, such as breast cancer or any other type of cancer for that matter.
Yeah, and Dr. Julie, I was just going to mention, I think I try to avoid the word prevention, like in this setting, because I think people misunderstand. Again, if you have breast, you're at risk for developing breast cancer. So I like to talk about risk reduction. What are the things that we have in our control? So Dr. Barbara outlined the things that we don't have control over, right? Our gender, age. As we age, our risk for cancer gets higher, across the board for the most types of cancer, except for those that are more specific to pediatric or younger populations. But what are the things that we have control over, right? And the number 1 and 2 modifiable risk factors for breast cancer and for all cancers, frankly, are tobacco and obesity. So I think strategies around kind of really improving wellness are really important. Now, no, at least in the United States, part of the challenge with being well in the United States is related to, Black skin color, unfortunately. There are a lot of pressures. There are a lot of those microaggressions and macroaggressions that happen on a daily basis. We all know that George Floyd, that whole situation, you know why George Floyd became a big deal in the United States? It became a big deal because of COVID. Because people were actually home and were able to actually watch a video of some man being killed, murdered, lifetime, right? That's why it became a big deal. But Black men are being murdered all the time. Again, Black bodies in the United States don't really matter. And so part of what we're trying to do is raise awareness about the fact that our social conditions, the social determinants of health, many of those things are driven by systemic racism. And so that's an important component too. And so I've got to say, part of the strategy around risk reduction is this awareness. I have my AAA that I like to talk to people about. Look, you need to become aware, you need to take action, you need to become advocates. And part of advocacy is not just being personally aware of our bodies and advocating in the healthcare system to make sure we get what we need, but advocacy needs to be broader about the systemic context, about what's happening on a day-to-day basis, those stressors. Because frankly, if you look across the board and you take people's blood samples and you look at Black blood versus white blood, our stress hormones are off the chain, at least in the United States. All right. So that actually contributes as well. That stress contributes to the obesity. That stress contributes to the inflammatory state that actually can then create an environment that people are at higher risk for cancer. So I think it's important to think about risk reduction. What are the things that we can do? Thinking about reduction of obesity, that includes nutrition and exercise, reduction of tobacco use, but reduction of stress, which again, that requires a whole other level when you're talking about being Black in the United States.
Yes, thank you very much, Dr. Karen. You've made, I could just give you a round of applause for that, definitely. Wilhelmina, I've seen that you've been trying to speak, so I'll
Yes, thank you. Well, Dr. Karen covered it. She hit the nail on the head. I was about to say some of the things that we can do, some things that are in our control in regard to lifestyle changes is eliminating stress. And for me, that means meditation. It means practice of spirituality, and it means just doing some form of slowing down. She talked about those microaggressions, and that's absolutely true. And we need to have a way to sort of dispel those incidences, and how we take in all that toxin and to sort of cleanse ourselves from it. So I was going to say, before she even brought it up, about taking time for meditation and Reiki or whatever form of eliminating stress or de-stressing ourselves that we could do on a daily basis.
We're of one mind, Ms. Wilhelmina. We're there, you and I.
a lot of people don't factor in how stress affects us. I mean, mentally, spiritually, emotionally, and how that affects us, how that can contribute to disease. So definitely we have to, do things that help to alleviate that stress. And as you had mentioned, Wilhelmina, excuse me, meditation, even with other things that we experience on a daily basis, fatigue. I think meditation, massage, yoga, acupuncture, all these things are so beneficial to us, and that we should kind of find time to see if we can incorporate that, whether we have disease or not.
Thank you, Dr. Shirley. And one thing that I have done to take it one step further is to incorporate art making in my daily life. And I bring that to the community because it is extremely important to get some of these things out of us. So a way to do that is in using art to express ourselves and to eliminate stress on that level. It really, really does work. And it's a good communication tool for me.
That's great.
Yes. So thank you so much for that input. It's amazing. Self-care is a big buzzword at the moment, but beyond being a buzzword, it really should be a way that we're living our lives, looking after ourselves. We're so used to working ourselves to the bone, trying to do the best we can, but we need to look after ourselves. So thank you for that apt reminder today to our panelists. So we've just got 5 minutes left. I can't believe how quickly the hour has gone. So I'm just going to take some questions from the audience. So I'll just throw this out to the panel as well. So the first question I have is, please can you discuss the prognosis of triple negative breast cancer in Black women and highlight any new treatments, especially for BRCA1 or 2 mutated cases? So I can throw that out to anybody who wants to take that question.
Sure. So let me just start by saying, because we didn't talk about treatment at all, we talked about risk reduction, but let me just say, anytime a person is diagnosed with breast cancer, the question that we as providers ask is, what are the tools in our toolbox? What are the things that we can actually do to help cure this cancer? Because we are curing breast cancers. Let's make that clear. Again, Ms. Wilhelmina, who's sitting there 25 years later, is a prime example of that, right? So we are curing cancers. So a couple of things. Number one, surgery is typically part of the cancer care journey, unless your cancer is stage 4, which means it has metastasized and gone to different parts of the body. And then we start thinking about systemic therapy, okay? But for breast cancer, even for later stage, I mean, Ms. Wilhelmina talked about the fact she had cancer in her nodes. There are surgical options that need to be discussed. And so whether it's a lumpectomy, meaning just taking out the tumor that's in the breast, along with maybe a sampling of the nodes, versus doing a mastectomy, which is actually taking all the breast tissue off and also taking out nodal tissue. Those are conversations you have with a surgeon about what is the best option, what's the best surgical option for me, if indeed you have stage 3 or less breast cancer. Now, also, there's the systemic therapy, which is in the form of either chemotherapy or hormonal therapy. So remember, I talked about those proteins that can sit on the surface of a cell. Estrogen and progesterone being 2 of them, normal female hormones that are there. And there are hormonal therapies that are coming in the form of treatments like, I don't know if we should use names or not, but there are hormone therapies that can be used that can actually target those particular proteins. There's also a targeted agent that goes after a protein that's called HER2/neu, which is actually a protein that actually can drive replication. And before we actually had this medication called trastuzumab that actually targets that, people with HER2/neu positive breast cancer, actually there was a death sentence practically. I mean, they died within 2 years of diagnosis. Now that we have this targeted medication, actually their survival is exactly the same as ER/PR positive breast cancers. Now, the one that is much harder to treat is the triple negative, because we actually don't have as many tools in our toolbox. We don't have the hormonal therapy to use because those receptors are not there, those proteins are not there, or the Herceptin, the HER2/neu protein, is not on the outside of that cell. So the triple negative breast cancers do tend to be harder to treat. I did not mention radiation. I'm a radiation oncologist. Let me just say this. Every woman who has a lumpectomy for their breast cancer needs radiation. And anyone who has lymph nodes that are involved, even if you have a mastectomy, needs radiation therapy. There are very few exceptions to that rule. If you're over age 70 and have estrogen receptor positive breast cancer, you may be able to avoid radiation therapy. But let me tell you, at least ask whether or not you need to see a radiation oncologist as part of your care, all right? One of the tools in the toolbox. There are lots of new things that are coming out, including PARP inhibitors that are being used for triple negative breast cancer. We know that the prognosis is not as good for triple negative breast cancer. However, again, early detection is key. So if it's early stage triple negative breast cancer, outcomes are very, very favorable, but really important to make sure that you're at a place where you have standard of care, where you have opportunities potentially even to join some research, because that's how we move the field forward. That's how we learn what's going to work, and whether or not the side effect profile is going to be the same in all communities is by us engaging in the research process. Dr. Barbara, did you have a comment? You looked like you were leaning forward.
No. So I think when it comes to treatments, to be fair, it's pretty much a secondary care decision. So the specialists make the decision when it comes to treatment. And from a very primary care perspective, our emphasis is on prompt recognition and early referrals. And I think no matter what kind of cancer a woman has, whether it's triple negative or it's a different kind of cancer that's hormone responsive, if a woman's detected earlier and starts treatment earlier, she's got better chances of survival and less chances of even having her breast taken out. So I think for us, from my perspective as a primary care physician, the emphasis on women should be aware of their own bodies, and we should be able to do a risk assessment and refer women when we think they are high risk, and obviously refer them on time, in good time enough to get them the best possible outcome.
Wonderful.
In terms of treatment, I did undergo a high-dose chemotherapy followed by radiation, followed by 5 years of tamoxifen. But before I did that, I did my research and I went to 3 different oncologists and got all the information that I could. Mind you, this was back in 1994 when I didn't have internet on my side. So I did a lot of research in the library, a lot of phone calls, a lot of speaking to other women who'd been through breast cancer treatment before me. So I think that's important to remember.
Wow. Thank you so much, Dr. Shirley, Dr. Karen, Dr. Barbara, Wilhelmina, for sharing today. This has been super educational and rich, and I hope that each and every person that has attended today has got a couple of key takeaways. Advocate for yourself, know your body, look after yourself, nutrition, exercise, and there's so many rich things that we've learned today. So before we close the call, can each of you just share how we can stay in contact with you? Just starting with Dr. Shirley, then Dr. Karen, Wilhelmina, and then Dr. Barbara.
Sure, I can give you my email.
Great, thank you. So if anybody wants to get in contact with Dr. Shirley, you can contact Black in Cancer at Black in Cancer, and then we can share that. Dr. Karen?
Yeah, I'm on social media, so at Dr. Winkfield. So please make sure you're following on Twitter. I'm on Facebook. I have a webpage, but I'm also one of the co-founders of a podcast called The 3 Black Docs, where it's myself and 2 Black medical oncologists. And we talk about healthcare. We talk about, the stresses. We talk about ways to reduce kind of risk and things that we can do that are practical and that are ways that we can actually just make sure we're engaging our family. So please check us out. And that's at 3 Black Docs, the number 3 Black DOCS. And so you can find us also on wherever your podcasts are, but also on social media as well.
Wonderful. Wilhelmina?
Hi, yes, I was just putting all my info in the chat. I can be reached on my email, which is sistastudio@gmail.com. I have a website, which is sista.org, SISTAAH.org. And I put my my phone number. You can text me or call me.
Wonderful. Thank you very much. And Dr. Barbara?
Yes, so I think like Dr. Shirley, I'll probably just send you my details, my email address, Twitter handle, and yes, you can contact me anytime.
Great. We can share those on our socials after the event. But I just want to say a massive thank you to Dr. Shirley, Dr. Karen, Wilhelmina, and Dr. Barbara for this wonderful event. Thank you, everybody, for attending and supporting this event. We have a another 3 events for this Black Family Awareness Week. So please do get involved in our other events. You will find this at Black and Cancer on all social media platforms or www.blackandcancer.com. So thank you very much, everybody, for joining us, and have a wonderful rest of the day.